Great. So welcome back. This is going to be the first part of a kind of a three-part lecture series on the remaining pages in your chapter 37 in your Egan's Fundamentals of Respiratory Care book. It's going to be talking about pharyngeal airways, kind of artificial airways and advanced airways, the process for intubation. A lot of information on tracheostomies is covered in this lecture series. Some procedures related to intubation, and then finally we're gonna finish up with some information on airway trauma, things that are and airway maintenance. All right. So to begin with, I just want to talk a little bit about upper airway obstructions. So a common airway emergency is going to be when the soft tissue of our upper airway obstructs or blocks that airway passage or upper airway passageways. This obstruction makes it so that we can't ventilate well. So that patent airway is essential for adequate ventilation, gas exchange. When you get into life support in a future semester, we talk a lot about making sure we're always recommending intubation in cases where a patient cannot protect their own airway. So some of the main causes for this upper airway obstruction may be loss of consciousness or central nervous system abnormalities. This is going to cause like the tongue to fall back into the posterior wall of our pharynx, blocking that airway. Another thing that could cause this obstruction is any type of edema. So any swelling, this is commonly related to post-extubation. So if an airway's been in place for a while and we take it out, that airway can start swelling, getting inflamed, especially in that glottic area, that space between the vocal cords. If that swells, that's kind of the narrowest point of your airway, and that can cause some obstruction. Any bleeding or secretions or foreign substances can block your air passages. This types of things we learned about when we were talking about suctioning. And laryngospasm. This is where your kind of vocal cords spasm and can kind of close when they're not supposed to be closed, and then that can kind of obstruct that airflow. Okay, so signs and symptoms. What is our patients going to look like when they have like a partial upper airway obstruction? They're going to have a lot of crowing, gasping sounds on inspiration, so that's stridor. If it's partial, they might have, they may be able to cough slightly, but if it's fully obstructed, you're going to have that inability to cough or make noise. As the obstruction worsens, you're going to have increasing respiratory difficulty. You could have poor to good air exchange depending on the severity of the obstruction. As patients try to work harder to breathe, to get airflow around that obstruction, their respiratory muscles are going to be doing more work, assuming more work. So you can have that exaggerated chest abdominal movement. And this is going to be associated without comparable air movement. So that's actually one way when we talk about obstructive like sleep apnea later on in the program. That's kind of one of those telltale signs of obstructive versus central sleep apnea. Is obstructive sleep apnea. Patients know that they're supposed to be breathing, want to breathe. Their respiratory muscles are trying to make them breathe, but they're not strong enough to pull past the whatever's blocking the airway, and no airflow or air movement's going to occur. Cyanosis also may or may not be present depending on the severity of this obstruction. As we move into complete upper airway obstruction, this is where patients lose the ability to talk at all. So sometimes with partial obstructions, you're just going to be kind of coaching the patient to try to cough it up on their own. You're not going to do a lot to interfere with this, because if it's something that they're able to bring up or cough up on their own, you want to allow them to do that. If you kind of interfere in the process, that can cause the obstruction to potentially get worse. aside from like this basic suctioning, you should be just encouraging the patient and supporting the patient if it's like a partial airway obstruction that's related to like food or foreign body. If it's related to like blood or secretions in the airway, you can support them with suctioning. If it's related to swelling, edema, then you're going to be starting to think about therapeutic adjuncts that could help them. So cool mist aerosols, racemic epinephrine, those are types of Decadron is a medication we can give through the IV to help with that. Those are the types of things you should be thinking of to help them if it's swelling. Okay, so complete obstruction, this is where things are getting real serious really quick. Patient loses the ability to talk. There's going to be increased difficulty, increased work of breathing. There won't be any air movement. The patient's going to end up being cyanotic. You're going to see these marked sternal, intercostal, epigastric retractions as those accessory muscles start to work and try to pull harder to get air into the lungs. These patients are going to be panicking because they are suffocating, essentially. And then eventually it's going to result in unconsciousness and respiratory arrest if you can't correct it. So this is going to progress fairly quickly to respiratory arrest and unconsciousness. Okay, so treatment of this, again, is going to depend on the level of consciousness and distress. If it's a conscious patient with a partial obstruction, you're going to monitor the patient. You're going to allow the patient to try and relieve the obstruction on their own. If it's conscious and complete due to food, foreign objects, you can do Heimlich maneuvers for abdominal thrusts to try to get dislodge the object or wait and you're going to continue to do that until the patient becomes unconscious or they get the object out. For unconscious or patients that are partial and complete obstruction, you're going to most likely assume that the obstruction is coming from their tongue in the back of their pharynx, and you're going to relieve that through either one of two methods, the head tilt chin lift method or the jaw thrust method. So head tilt chin lift, I'm going to play this video here, is a maneuver that we're going to use to open up most basic airways. Okay, so the indications for this are airway obstruction caused by that tongue in the back of the throat. Okay, so there's a nice picture there. It's going to be contraindicated. So we're using this maneuver on everybody except for ones that we feel like have cervical spine injuries. So if they have any evidence of trauma that we suspect a cervical spine injury, we would not do the head tilt chin lift.
So thinking about basic airway maneuvers, the first one that we can do is a head tilt chin lift. And to do that, we're going to take one hand and place it just on top of the patient's forehead. Take our other hand and just put two fingers just underneath their mandible or their jaw. We're then just going to lift gently upwards with this other hand. And in doing so, that opens the patient's airway, removes the tongue off the back of the soft palate, and hopefully provides us with a patent airway initially.
Okay, so that was your head tilt chin lift maneuver. Now moving on to the jaw thrust maneuver. This maneuver is suitable for patients who have some evidence of a spinal cord injury. So they're going to demonstrate this maneuver to you now.
This is going to be the side view of the jaw thrust. Remember that we want to use this if we're suspecting that the patient does have a cervical spine injury. We're not actually manipulating the head, the neck, or anything like that, but we're actually just lifting the jaw straight up. You also want to be careful with this too if they've got facial trauma, specifically around the cheekbones or suspecting a broken jaw, because that's going to eliminate the ability for this to work like it's supposed to. So our landmarks are going to be your thumbs on the cheekbone of the patient. You're actually going to use this as your pressure or a fulcrum to lift the jaw up. And you're going to come down here below the earlobes, and you're going to find the angle of the jaw. So on the mannequin here, it looks like it's about here, but it's really not. It's down here on the mannequin just under the earlobes. So you're pushing down on the cheekbones, and at the same time you're lifting up on the bony prominence of the jaw to lift that tongue off of the back of the airway. It may take a little bit of work to do this, and you want to be careful that you're lifting up and you're not compressing it this way so that the jaw closes on itself. All right, from the front angle, when we're doing the jaw thrust, remember that your thumbs are going to be on the cheekbones and your index fingers are going to be on the angle of the jaw just under the earlobes. So from the front, you're going to push down with some pressure and also lift up with some pressure. And you want to displace that jaw forward. Now, if you're compressing the jaw too much and you push it closed, it'll look something like this. So it's important to make sure that we're lifting up instead of in.
Okay, so now that we've talked a little bit about airway obstructions and how to do that head tilt chin lift and open the airway and support our patients with obstructions. Now let's talk about some artificial airways. The basic ones being oral pharyngeal, nasal pharyngeal. All right, so oral pharyngeal airways, kind of the indications for use. Sometimes these are called oral airways or OPAs. They're used primarily in unconscious patients. This is because of, if you're using these, on a conscious patient, this is definitely going to cause gagging and emesis. So we use these to maintain the airway by lying between the base of the tongue and that back wall of your pharynx, prevents the tongue from falling back, helps you facilitate bagging, manual ventilation with a bag valve mask. It's used to prevent biting on the ET tube, used to guide a suction catheter into that glottic area to help facilitate suctioning, or you can use it during special procedures such as bronchoscopy for the same thing. Okay, so there's a couple parts to these. This widening at the opening of it is called the flange. It's on the proximal end, so this is the end that sticks out of the patient's mouth, prevents this from sliding deeper into the airway. You never tape an oral airway in place, okay? Because we want to be able to easily pull these out in case the patient throws up. Based on how these fit in the patient's airways, these tend to not move around. So once they're in, if you've sized it appropriately, they're going to be in and you don't have to worry about it. There's a curved body to this that's going to follow along the hard and soft palates of the patient's airway and help to displace that tongue away from the back wall of the pharynx, okay? Usually oral airways are not going to be solid, so there's either going to be a hollow center to them, or they'll have channels along the side to help facilitate air movement and for that suction catheter. Okay, so a couple different pictures of different ones that are out there. These are the Bierman ones. This just has the channels on both sides. Goodell is the one with an inner channel, helps facilitate suctioning. And then both of these down here are used for fiber optic bronchs. So they're kind of a wider open one. And this channel here in the middle is what you would put like a fiber optic bronchoscopy device into. We use bronchoscopies to take a deep look down into the patient's lower airways. They can do it therapeutically to like remove secretions or mucus plugging. Or sometimes they use it if there's a lot of pulmonary bleeding, they'll go down there and cauterize or put pressure on the bleeding to help stop the bleeding. So those are examples of therapeutic bronchoscopies. Diagnostic bronchoscopies are when they use that scope to go down into the lungs. They might take a biopsy of lung tissue, or they might do a brushing of the airway linings to look for cancer diagnoses. They might do washings of the lung tissue with the bronchoscopy equipment to look for sources of infection as well. So these oral airways are helpful with that just because those are very expensive pieces of equipment. And if your patient bites on it even a little bit, you will wreck the fiber optic fibers and you'll be throwing a $10,000 piece of equipment in the trash. Okay, so sizing and insertion, you want to measure the airway from the center of the lip to the angle of the jaw to ensure proper depth length, okay? Before you put it in, you want to remove any substances from the mouth, hyperextend the neck. They talk about this cross finger technique to open up the patient's airway. So it's just kind of like you would do to snap your fingers. You're going to do the same kind of motion to open up the patient's airway. Insert the airway with the tip pointing towards the roof of the mouth. Once you get the airway past the uvula, then you can rotate it 180 degrees. So you're going to insert it upside down. Once you get it into the back of the patient's mouth, that's when you can rotate it into the correct position. Okay. So some hazards with using oral pharyngeal airways is gagging. Patient may gag or fight against the airway. In that case, you want to remove it immediately. If it's inserted improperly, you're going to end up pushing the base of the tongue back into the throat, increasing the risk of obstruction. The airway is too large. You are, meaning the oral airway that you're inserting, if it's too long, that might interfere with that epiglottis, and it may push it into that laryngeal airway and cause an obstruction. If it's too small, it may be aspirated, and it may be ineffective or leading in obstructions as well. Okay, so moving on to nasopharyngeal airways. These are also called nasal airways, NPAs, or sometimes referred to as nasal trumpets. These are used in either conscious or unconscious patients. So if your patient's conscious, you have to use a nasopharyngeal airway. If they're unconscious, you have to decide which one's better, oral or nasal. So we use it to maintain that airway, lies in the base of the tongue, keeps that base of the tongue away from that posterior wall, just like the oral airway does. Commonly used mostly to facilitate that nasotracheal suctioning. Okay, so we put that trumpet in, and then that gives us an access through the nose, easily through the nose, helps cut down on the irritation that we're going to be causing to the airway when we're NT suctioning. It's also used to maintain airways during seizures or post-surgical facial surgeries. So if you've had facial surgery and you've had to have something, sewn up or wired in your oral cavity area, you're not going to want to put an oral airway in. Nasal airways would be the way to go. Seizures, again, if your patient is seizing, usually during seizures, patients will bite down really hard. So you literally won't be able to get anything in their mouth while they're mid-seizure. So that's why it's easier to facilitate putting the nasal trumpet in. If your patient's at risk of seizures, you wouldn't want to necessarily have an oral airway in, just because as the patient bites down on that, it could possibly break and aspirate something. So you don't want to have anything in the patient's mouth when they're seizing. Just like the oral airway, nasal airways help to facilitate bag mask valve ventilation. Patient can still eat, drink, speak with this area in place, so it makes it much more comfortable for those conscious patients to, kind of go about their daily lives if we need to maintain that airway in place. These can be taped into place because of the fact that they're more of a kind of long-term use, and we're not worried about that MSS. Okay, so you have this flange again, the proximal end, that helps prevent it from going too far into the nose. And this can be secured with tape or a safety pin. So sometimes I've seen people stick a safety pin through the top of this and then tape the safety pin flat to the patient's face as a way of securing it. I'll show you in lab a method that I use when I'm taping these in place. Hollow cannula, again, maintains that patent airway, facilitates that suction catheter. This distal beveled tip here should rest behind the uvula, which is that dangly down thing in the back of your oral airway. Okay, so different types or different looks that NPAs can take. These are the ones that we have in our lab, but they can be these kind of opaque blue ones. These orange ones, they all kind of do the same thing, so there's really no benefit of which type you're buying. It's just kind of which ones you have per your facility. Okay, so sizing and insertion. You want to select the proper size by measuring the airway from the tip of the nose to the earlobe. The outer diameter of the airway should be equal to the inside diameter of the patient's internal nair, meaning how big this is on the outside should be no bigger than how big of an opening you're trying to put it in. You really want to make sure you're lubricating the airway well with water-soluble gel, inserting it into the patient's nostril. The flanged end should then, by the time it's inserted, rest against the nose. Okay. And if you were looking inside the patient's mouth, you should see that distal end resting behind where the uvula is. You can place, again, that tape around the flanged end to secure it in place. And we will show you how to do that better in lab. So a few hazards of nasopharyngeal airways is if you put in one that's too small, it might end up getting aspirated further into the airway. And then that nasal irritation, if these are going to be used long term, you have it in place. You want to make sure you're alternating nostrils daily so that you don't cause any skin breakdown. All right, so talking about manual resuscitators now. And again, some of this stuff is a little bit added in for your chapter. So it might not, if it's not written specifically in your chapter, it will not be on this exam. But I feel like it's important for me to mention these things about airway obstructions and manual resuscitators in this lecture and add this information in for you, because I feel like if I don't, where you're at, it's not gonna, everything doesn't tie together the way it's supposed to. Okay. So don't freak out if you're not seeing references to this stuff about partial or complete obstructions that I talked about in the beginning of this lecture, or the use of these manual resuscitators in your chapter. Means it's not going to be on the test because I'm only testing on what's in the chapter, but it's still important information as you're working through these things in labs and, even just in a clinical setting, when you're doing these things, you kind of need to know about the next piece of this of resuscitators and bagging a patient. So here's kind of a quick video. This guy does a really good job of discussing
This is Kiki Palmer.
different
But
really
baby,
good techniques
so is
for using bag valve masks.
So
or
Rodney
ventilators.
Dangerfield, his big thing was, I don't get no respect. He had a signature red tie. I don't get no respect. Well, I can tell you that mask ventilation, when it comes to airway management, is the I don't get no respect kind of a thing. When people talk about managing the airway, it's always like, let's intubate. Let's put the laryngoscope in. I got to get the tube in and stuff. Well, you got to walk before you run, and mask ventilation will probably actually save more lives than intubating in the course of your career. So let's not leap into intubating. Let's focus on good mask ventilation. Mask ventilation will, first of all, that's the first thing you can do. You can always mask ventilate, while they're getting the equipment. That'll often stabilize your patient. It'll often make intubating easier. And why is that? If you're trying to intubate someone and they're desaturating, they're going to hell in a handbasket, your head is going to not be particularly relaxed. Whereas if you can mask someone up first and get their SAT at least up somewhere in the 90s, you're going to be much more relaxed when it comes to intubating. So masking is something we need to think about and master and focus on when it comes to airway management. It's not something to be skipped or just like, oh, that's just squeezing the bag. It really does matter. So now, a couple things about mask ventilation. First, like everything else, you want to do a history and a physical on the patient to see if there's anything that's going to make mask ventilation difficult. Beards in particular are a real problem. If someone has a big beard or they have a big mustache, or even if they have kind of stubble, I have a little stubble here myself, it can make it hard to get a seal. It can make it really hard to get a seal. So you want to see that. You also want to see if someone has a fixed neck or if they're in a neck collar or some other thing that would prevent you from doing what you like to do, which is extending their head so you can get a nice mask fit. Well, if someone has an unstable neck or they're in a collar, you can't do that. So like everything else, you have to do a history and a physical, focusing on not just intubating, but how you're going to mask the person. Do they have a full stomach? If they have a full stomach, you don't want to be masking them for a real long time. But of course, you will mask someone if they're desaturating. Well, I'm just going to sit here and let them desaturate. So for all those reasons, history and a physical, which is a part of everything else in medicine, is very much a part of mask ventilating too. Now, what's one of the things you can really do, particularly in patients who have a larger BMI? Well, one of the things that can really help is tilting the patient up. Remember, if you tilt a patient up, you are taking weight off the diaphragm. You're making it a little easier to get the air in. You're giving yourself a little FRC. And for all those reasons, tilting a patient up, if I had a dime for every time I ran in a room and they were in trouble and I tilted the patient up and we got out of trouble, I should certainly be a rich man. And as you can tell by my dress, I'm not. So tilting them up really helps mask ventilate, helps an awful lot. So think about that. When you're mask ventilating, you're always concerned that they might aspirate, so make sure you have suction nearby. Make sure you have suction like right away. Now let's get into the actual mechanics of mask ventilation. Okay. My hand forms a pretty good seal on this side. On this side. It doesn't form a particularly good seal over here. So a lot of times I've had to ask people, hey, come over here, just push down here. Okay? If I had a gigantic hand, if I had a Shaquille O'Neal hand, I could put it all the way around, but I don't. So you want to get a good seal here. Notice my finger is on the jaw. It's on the bone. It's on the hard part, so I can lift it up. Don't put your finger on the soft tissue. Don't put your finger in the soft tissue. All you're going to create is a bruise. You're not going to really lift up. Lift up, and the idea is to lift that chin up. That pulls the tongue forward, and then you can get some air in. When you squeeze the bag, notice I'm going to do gentle ventilations. Gentle ventilations, okay? If I go like this, I'm going to probably push air into the stomach. This is no way to ventilate. Also, the literature on CPR has told us that hyperventilation impedes venous return and worsens outcome when it comes to resuscitation. So you want to, how many times do we breathe? We breathe maybe 10 or 12 times a minute. That's the way you want to breathe. If you see that you're not moving air, if you don't see end-tidal CO2, if you have access to that, if you don't see the chest rise, if it just doesn't feel right, then adjust something. Adjust their head. Notice how I extended. Again, can't do that in case of neck injury. Extend the head, see if that helps. If that doesn't help, here's an old trick that I've only seen in one book, and the book I wrote. Tilt their head to the side. A lot of times when people can't mask, somehow if you just tilt their head to the side for some reason, I don't know why, it really helps. Tilt their head to the side. And we have airway adjuvants too. You can always put an oral airway in. You can always put an oral airway in. There's 100 ways to put in an oral airway, but the idea is to make sure it's lifting the tongue up. Don't just jam it in there, in which case it could actually worsen things. So make sure this is like that. And you mask away. Another thing that helps a lot of times when people have particularly a lot of soft tissue caving in, say an OSA patient or a patient with a big BMI, a nasal airway helps too. Being very aware of the fact that this can cause a nosebleed. So, patients on Plavix, you're going to think twice about this. But with these adjuvants in, you should be able to mask the patient. Why do I dwell so long about masking? Well, let's say you can't intubate. You might have to mask for a long time. Or you might want to mask until, say, another airway expert comes. Or you want to mask until you can get a fiber optic in the room. So it's really worth spending some time making sure you really can mask ventilate a patient. Now, I'm going to focus now on my left arm. And I'm going to say, let's say we encounter a situation where we really can't intubate, and we got to mask for a long time. Maybe you're at a facility. You graduated. You're at a facility. There's no anesthesia guy readily available. There's no fiber optic. You have to mask for a long time. If you mask like this, I don't care how good a shape you're in. Your arms are going to get tired. Okay, if you have this kind of claw-like thing. Whereas if you watch me how I lean back now. See this? See how relaxed that is? What I'm doing now is I'm just leaning back. I'm holding the jaw. I'm leaning back. All the work's being done by my tendons up here in the shoulder. It's not being done by my bicep and by my hand muscles, which will get tired. Lean back. This is very similar to someone if you've ever water skied. If you water ski, you basically lean back, right? You lean back. And you can water ski all day like that. If you try to water ski like this, you're going to cramp up and not going to be able to water ski very long. And this is for that rare instance that I hope you don't encounter, where you have to mask for a very long time. This works. This doesn't work. Okay? So that's it for mask ventilation. Quick review. Do a history and a physical. See if there's going to be something problematic about masking them, like a beard or something. Tilt them head up if you can. Obviously, an unstable patient in Trendelenburg, you can't. But if you can, tilt them up like this. Use the airway adjuvants if you need to. Get that, see how I got that head in a good position? Get that head in a good position. Squeeze slowly. Don't do that. Squeeze slowly. Tilt their head to the side if you're not getting air in. And then put an oral and or a nasal airway in if you can't get any air in. So that's a little review on mask ventilation.
All right, so that video was kind of a good overview. I think he did a nice job explaining a couple different tips and tricks that he's learned over the years of having to do this. But I think one of the things from the video that I would like you to kind of remember is that this is a skill set too. We get really excited about intubations and some of the other things we do, but being able to effectively ventilate somebody with just a mask and a manual resuscitator and maybe like a airway adjunct is super important, because you're going to be in situations where you're having difficulty intubating, or it's taking somebody a little, the person that's performing the procedure a little bit of time to get to the bedside. So you want to make sure that you're ventilating the patient adequately. So your ability to open the airway, create a good seal with the mask, and ventilate appropriately is going to be important. So when do we use manual resuscitators? Again, it's for that manual ventilation, when the patient, to take over for the patient who's not ventilating themselves properly. We can use it for hyperinflation of the lungs before and after tracheal sectioning. This is not a common practice anymore. And then we use it a lot during transport. So if a patient's on a ventilator in the ICU or in the emergency department, we need to transfer them to a different part of the hospital, we should always be bringing a manual resuscitator with us. So design of the manual resuscitator, all are basically about the same. There's typically a non-rebreathing valve with a standard universal adapter that connects to the mask or an ET tube, trach tube. All of these standard adapters are all the same. They're a 15 millimeter adapter. It's called a universal adapter. All respiratory equipment has to have one so that all stuff will fit. So we're not running into a situation where we're standing up at the head of the bed not knowing what to do because our mask doesn't fit with our bag. So they also house typically an exhalation port. This prevents that rebreathing of the exhaled gas. When you're using a self-inflating bag, which is what we typically use for patients who adult patients or on transport, they have intake valves that allow the bag to function independently of a gas source. So that means, when it means self-inflating, it means I don't have to have it hooked up to oxygen or air in order for this bag to work, which is super important during transport, because if you lose your gas source, you lose your ability to ventilate if you don't have a self-inflating bag with you. That reservoir attachment should be on the back of the bag that connects the bag to like an intake valve. This ensures high levels of oxygen being provided. So if you don't use a reservoir, your ability to get a lot of oxygen or high concentrations of oxygen decrease significantly. And then there's some other things when we're talking about how to ensure the best oxygenation. A couple different things we'll cover with how we actually squeeze the bag that can help. Okay. So here's kind of a picture of this manual resuscitator. We talked about the exhalation valve. This is usually right along the side at the kind of the front of the bag. You can attach a PEEP valve to it. This helps us maintain a certain pressure during exhalation. We'll talk way more about PEEP and the importance of PEEP next year, but this is where most of them will fit. Some of these bags have like a pop-off valve or a pressure relief valve, which is located here in this picture. This ensures that you're not delivering too much pressure to the patient. So if the pressures inside that bag exceed 40 centimeters of water pressure, that valve opens up and releases that excess amount of pressure. Okay. So here we are hooked to the face mask. We have the self-inflating bag here. We have an air inlet one-way valve with that reservoir socket here. We have the air inlet and a pressure release valve on the bag back here, and a reservoir bag. My O2 tubing's hooking up to the bag here. So every self-inflating bag will have these components, just they might look slightly different depending on the bag that you're using. Okay, so big takeaways with this is we always need to use that reservoir attachment. Otherwise, we're not going to get 100% of FiO2. We want to use the highest flow rate available. So we're going to turn our flow meter, our oxygen flow meter up to full blast. The other thing, big important thing for me to remind you guys of is to slow down. Slow down. Usually when we're in this situation where we're manually ventilating a patient, there is a lot going on. There's a lot of energy in the room. You certainly will feed off of that energy, and you can end up hyperventilating your patient very easily without even paying attention. It's very hard to focus in code situations. We get distracted by other things that are going on, and then all of a sudden you'll realize you're just cooking away, squeezing that bag at 20, 30 times a minute. So by slowing down your respirations, you're allowing that reservoir time to refill. So because your reservoir refill is having time to refill, that means you're going to give a higher percentage of oxygen to the patient. So fast respiratory rates decrease O2 delivery. It's also going to reduce your cardiac output. We talk about in CP Phys how your heart and your lungs are kind of roommates. They take up the same area of your chest. If your lungs are doing too much work and they're taking up too much room, they're spilling over into the room that your heart's supposed to have, and it's gonna, then all of a sudden your heart doesn't have enough space to fill up and pump properly. So if I ventilate the patient too much using positive pressure ventilation, then my heart is going to get squeezed, and it's not going to get enough blood back to it, and it's not going to pump the way it's supposed to, and that is going to reduce the amount of cardiac output, or amount of blood that leaves my heart every minute, which is not good to somebody who's critically ill. You're also increasing the risk of aspiration by breathing, hyperventilating, especially primarily before you have an advanced airway in. If I'm just bag masking my patient, that air, I'm hoping I'm doing a good job, and most of that air is going to end up in my lungs. But no matter how great I am at this, some air is going to end up in my stomach. Just know that going into it, that as I'm breathing for my patient with a mask and a bag, manual resuscitation bag, I'm going to be ventilating the lungs, but some air will be entering into the stomach. The more air that gets into my stomach, the more inflated my stomach gets, the more my stomach goes, hey, I'm over full and I need to eliminate some of this stuff that's in me, and then your patient's going to vomit. Okay. Vomiting is a very, 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 very frequent occurrence with somebody who's been mass ventilated for a while if we don't decompress that stomach quickly with an NG tube or an OG tube, which is a nasogastric, oral gastric tube. So the faster I bag, the more air, when you're thinking about airway resistance, and we kind of talked about this in CP Phys, and we'll talk about it in lab, you think about airway resistance, this is how, what things affect the flow of gas through my lungs. The faster I breathe, the faster that flow has to go through my lungs, right? Because that flow is going faster, I need more pressure to get it where it's supposed to be. Your lungs are going to go, air, water, everything is going to go path of least resistance. So if it's easier for that fast flow of air to just go into my stomach and fill that stomach up like a balloon, that is where the air is going to go. If it's easier for it to go into the lungs, that's where it's going to go. So by slowing down your rate, slowing down how you're delivering those breaths, you're going to encourage more air to go into the lungs and less air into going to the stomach. Hyperventilation also does cause vasoconstriction, which decreases blood flow to the brain. So you'll learn about this in CP Phys again, as CO2, when you're talking about chemoreceptors in the body, as your CO2 levels decrease, you're going to end up with vasoconstriction, meaning your blood vessels are going to kind of start constricting in your brain, which is going to slow down blood flow. So you're going to decrease blood flow to the brain, which is not good when you're already have low levels of oxygen coming into your body because of respiratory arrest. Okay. Last thing is that this is again something that we are going to talk more about in CP Phys, is we talk about the oxygen hemoglobin dissociation curve. So this curve is kind of the graphical representation of how much hemoglobin likes O2. Okay, so we know that, or by this point, you should know that you transfer hemoglobin throughout our body bound to oxygen. That's about 97% of the oxygen that gets transported to our tissues is bound to hemoglobin. Okay, so in our lungs, we want hemoglobin to be really attracted to oxygen, meaning that it's going to bind to that oxygen. It's going to be in its puppy love phase. It's going to just love that oxygen so much it's never going to want to let it go. That's how we want hemoglobin to act around oxygen when it's in our lungs. Okay, when our hemoglobin gets to our tissues, we want our hemoglobin to kind of be sick of oxygen by then. They're in a toxic relationship, and the hemoglobin, kicks oxygen to the curb, and then oxygen can transfer out of the blood into the surrounding tissues. Okay, that is how it is supposed to happen. We need it to happen like that for our bodies to function properly. So when we talk about the oxygen hemoglobin dissociation curve, we talk about it shifting right and left. Okay, so when it shifts to the left, that means that hemoglobin is going to love oxygen more, really love that oxygen, puppy love that oxygen. It's going to pick it up from the lungs, but it's going to not give it up when it gets to the tissue level. And that means that it's not really doing what it's supposed to do, because oxygen doesn't do me any good if all it does is hang out in the blood with the hemoglobin. It needs to get dropped off when it gets to the tissues, so the tissues can use it for cellular metabolism. Don't worry. I love the oxygen hemoglobin dissociation curve, and I will talk to you guys about that for the next, year and a half until you run screaming for the hills away from my CP Phys talk. Okay, so hazards of using manual resuscitators. Some things to just be aware of. Leaks can occur during inspiration if you don't have the mask fitted properly or sealed properly. And the equipment can malfunction. You can have sticky valves inside and malfunction. I've opened up resuscitation bags before, and I usually always check them by holding my finger over the valve and squeezing the bag to make sure that I can squeeze the bag and the exhalation valve opens up. And I've done that before with a brand new bag and wasn't able to squeeze the bag, so I know something was sticking or wasn't seated properly, had to throw it out before I used it on the patient. Dirty valves also cause equipment malfunction. Medical emergencies codes are messy. If you guys have watched one yet, they're messy and they're dirty. A lot of times, because I'm a weirdo, I will put I will always carry bacteria filters with me, and I put bacteria filters on my bag so that I'm not getting whatever's coming up from the patient, I'm not getting into my resuscitation bag. It goes into the bacteria filter. I can throw the filter out, put a new one on. We're good to go. If you let a bunch of gunk and grossness from the patient get into your bag, that you should throw it out after the code is complete, because if it's allowed to stay there and dry, those valves definitely aren't going to work properly. Big thing with these two is just always, always, always double check your oxygen. This will happen to you as well. You will walk into a code, you won't be the first one there, so you will take it for granted that the bag is hooked up to oxygen and the oxygen is turned on to 15 liters. So the first thing I do when I get to the head of the bed and I'm taking over mask ventilation, I am double checking that it is actually my resuscitation bag that is hooked up to the flow meter and that the flow meter is on at 15 liters. This has happened to me a good 10 times where I've walked in and, we're coding the patient and the bag isn't on the oxygen or isn't turned on. So definitely this is something good practice to just double check that every single time. Okay. Oops. Okay, so talking about your, now moving on into kind of some more alternative airways. These are our supraglottic airways, meaning that it does not go through that glottic space. So these act more like OPAs, NPAs, than it's kind of a combination of both. Doesn't enter into that glottic space, so it's not entering into our lower airway, but it's still helping to facilitate ventilation. So the main one here is going to be your LMA, laryngeal mask airways. These are designed to be used as an alternative to face mask, or and typically used during surgery, when actual tracheal intubation is not necessary. Also, we use these in emergency when you can't get the patient intubated after several attempts. Again, intubation, when we get to that requires a skilled provider to do that. As you practice in lab, you're going to realize how dang hard it is to intubate a patient. So using laryngeal mask airways is a great alternative. Because this is going back into the back of the throat, this is going to cause gagging, could also cause laryngospasm. So you want to make sure that the patient's anesthetized during insertion. So the patient needs to be unresponsive or have sedation medications on board for insertion of these airways, just like your oral airway. Okay, so a couple pieces for this. There is usually a big, large cuff that helps seal this in the airway. There's a dome, air tube, this 15 millimeter adapter. Like I said, that's our universal adapter. You have an inflation line and a pilot balloon that connects to this cuff here. So that helps us inflate this cuff and seal off the airway. Okay, so indications for use, if I'm having difficulty with just manually ventilating the patient with a mask, I would consider putting a laryngeal mask airway in. Again, after unsuccessful intubation attempts, or if there's no trained intubator present. So common question I get is whether or not, who gets to intubate at hospitals. So under our Wisconsin state license and our scope of practice, we have the ability to intubate patients. Okay, but that does not mean that the hospital facility that you go to work at is going to train you and consider you competent for intubation. Okay, so you will have to, depending on where you go and work post-graduation, you may or may not be trained as somebody to intubate patients within your facility. So if you're at a code and you have no trained intubator present and you're struggling to ventilate, laryngeal mask airways are simple, easy to insert, great in emergency situations when you can't get the patient intubated, or again, like I said, in elective surgeries when the patient doesn't require intubation. It's a nice thing for surgeries to do rather than have to go through the intubation process. Okay, so contraindications, if you're not, even though these are simple, they don't require a lot of training, you still need to know what you're doing in order to insert them. It's not like anybody can just pick it up and know exactly what to do. Most of it has to do with sizing. You want to make sure you're picking the correct size for the patient, and you want to be well trained enough in ventilation to understand placement of this, where it's actually being placed, and how to ensure you're getting adequate ventilation after it's been placed. These, because of where they sit in the airway, they do increase your risk for aspiration. They sit supraglottically, so meaning I'm not sealing off my airway, I'm just kind of resting above it. So if my patient does vomit, I do have a risk that some of that MSS will end up in the trachea, which when you get to respiratory disease and you learn about aspiration pneumonias, you know that those are pretty wicked, nasty versions of pneumonia with high mortality rates, so we want to avoid that whenever possible. Okay, so advantages of it again are quickly inserted, more effective delivery of your tidal volumes to your patients rather than just the bag mask ventilation. Less gastric insufflation, meaning my stomach's not going to fill up with gas as much because I'm going to do more directed ventilation to the trachea. It can ventilate equally as well as an ET tube in the short term, and it's going to cause less trauma to the airway than intubation does. So disadvantages, again, doesn't protect against aspiration, can't be used if the mouth can't be opened. So your patient needs to be able to open their mouth fairly widely for you to be able to insert this, and can be difficult to use if you're using high pressures, high airway pressures. To deliver your volumes to your patient. So if my patient's lung compliance is really stiff, that balloon is really stiff, I'm going to need more pressure to inflate that balloon. That can cause difficulty with these. And again, any abnormal anatomy is going to make these difficult to use. So the quick video here. Oops. 1 second. That video is not working. Okay, let's see if I can post that separately, that video. So weight-based sizing for these, there's a quick chart in here that tells you based on the patient's size, what size LMA you should use. So adult females, they're going to be kind of more of that. Some of them, small adult females will be 3s, more average size adult females will be like a 4. Most adult males will be 5s. Small adult males will be 4s. So somewhere in the 3 to 5 range is where you're looking for your adult patients. And then there's the sizing for children. And then along with the sizing based on weight, you have kind of how much volume, how many milliliters you need to inflate the cuff with for proper seating. So for an adult female whose ideal body weight is about 50 kilos, so that's about 110 pounds, that would be, I'm 5'3", so that would be around where, if I was my ideal body weight, that's around where I should be. You would put a size 3 LMA in me and you'd inflate it to about 20. Okay. So again, this is based on ideal body weight, not actual body weight. Everything in medicine is based on ideal body weight. That extra poundage we put on over the holidays doesn't factor into anything we do in respiratory care, because it's all going to be based on a lot to do with height. Okay. We also have something called an esophageal tracheal combi tube. This is a double lumen, meaning 2 tubes. Each runs parallel to each other. Once inserted in the pharynx, you have one balloon that occludes the pharynx to prevent air from leaking out the nose and the mouth. So you have a big balloon on the top that seals off the upper airway. And then there's a balloon on the bottom that's inflated and seals off, whether it ends up in the trachea or the esophagus, one of each of those. Okay. So these are used when your patient has a, similar to LMAs, we have unsuccessful intubation, you don't have a trained intubator present, you can't fit a mask and ventilate with a mask easily. This is when you would consider using a combi tube. There's really, because this doesn't go into the esophagus, or this goes into the esophagus instead of just sitting above in that supraglottic area, most places prefer to use LMAs. So contraindications, if the patient's had an intact gag or responsive, you're going to need to sedate them. Any type of esophageal disease, so esophageal varices, esophageal cancer, anything like that, you would not use a combi tube. Then you're going to choose an LMA. If the patient ingested any caustic substances, so if the patients drink all sorts of crazy things. So if a patient drinks something that they're not supposed to drink, you can assume that there's going to be damage to that esophagus, and you wouldn't put one of these in. If you suspect an airway obstruction, meaning like a foreign object in the airway, you would hesitate to use these because this could push that further down where you don't want it to be. And combi tubes can't be used on anybody less than 4 feet tall. Okay, so advantages again, doesn't require a lot of training. You don't have to visualize anything because you're just inserting it down the airway. We use these in patients. You can use these in patients with suspected neck injuries because I don't have to tilt the head back or anything. And because I'm sealing off the esophagus, I'm reducing my risk for aspiration. Okay, so disadvantages. You can end up with the port of this combi tube becoming occluded with secretions. You kind of have to understand how the combi tube is designed, so you make sure you're ventilating through the proper tube. Like I said, that's dual lumen, so there's 2 tubes. There's a very, very large balloon at the top of this, so that can cause some tissue trauma when you inflate that. You're not going to be able to suction the trachea because most likely this combi tube is going to end up in the esophagus. So here is a video on combi tubes.
The esophageal tracheal tube is a supraglottic device that providers can insert without interrupting chest compressions and without visualizing the glottis. The esophageal tracheal tube is made up of 2 lumens permanently stuck together. Each tube can provide oxygen to the patient, depending on how it's inserted. The longer blue-colored tube, marked with a number 1, provides ventilations through 8 small openings in the pharyngeal section. The shorter, clear-colored tube, marked with a number 2, provides ventilation straight through the end of the tube. Once inserted, the distal end of the device will either rest in the esophagus or the trachea. If the tube rests in the esophagus, which happens most frequently, the cuff blocks the esophagus and air flows through opening number 1. If the tube comes to rest in the trachea, however, the provider can use opening number 2 to deliver ventilation without having to reinsert the device. The esophageal tracheal tube comes in 2 sizes. A 37 French is used in patients who are 4 to 5.5 feet tall. A larger tube, a 41 French, is used in patients more than 5 feet tall. To insert the esophageal tracheal tube, verify that the cuffs will hold air. The pharyngeal cuff, marked number 1, requires 100 milliliters of air. The distal cuff, marked number 2, requires 15 milliliters. Deflate the cuffs and lubricate with a water-soluble gel. Hold the esophageal tracheal tube in your dominant hand. With your other hand, grasp the tongue and jaw between the index finger and thumb and pull to fully open the mouth. As you insert the tube into the mouth, avoid catching the cuffs on the patient's teeth. Advance the tube smoothly but continuously until either the teeth or the ridge of the gums is between the 2 black rings on the tube. Do not force the tube. Keep the device in a midline position by aligning the black stripe on the tube with the nasal septum. Once the tube is situated, use the large blue syringe to inflate the pharyngeal cuff through the port labeled number 1. Then use the smaller syringe to inflate the distal cuff through port number 2. Begin ventilation through blue lumen number 1, checking for adequate breath sounds over both sides of the chest and over the epigastric area. Watch for chest rise. If the esophageal tracheal tube is correctly seated in the esophagus, you should hear no sounds in the epigastric area when you squeeze the bag mask device. However, if you do not detect chest rise or breath sounds, this may mean that the tube is seated in the trachea. Connect the bag to the clear lumen, marked number 2, and provide ventilation. Verify breath sounds and watch for chest rise. Caution, it's critical to confirm the proper placement of the esophageal tracheal tube because inflating the stomach with air can cause fatal complications.
So as the video mentioned, you're not going to be using king or combi tubes for patients under 4 feet tall. If the patient's fairly short, you can use a 37 French, but most adult patients are going to be over 5 feet tall, so you can use a 41 French. It's really just important that when you're inflating the cuff, you inflate the blue cuff first, then you inflate the white cuff, and then you're going to check for auscultation by listening through the blue and the white tube to see which one, and auscultating over the lungs and the stomach to see which one ventilates the lungs. Okay, so for King Airways, this is very similar to the combi tubes. There's 2 balloons are inserted and the patient's ventilated through the holes between the cuffs. There's 3 sizes based on height. Since these are shorter than the combi tubes, it's unlikely to be placed through the vocal cords. So regardless of where this goes, it's not going to go through the vocal cords typically because it's too short. Oops, sorry. That video's not. Okay. So if you're looking at this picture here, you can see this second balloon typically ends up in the esophagus. Even if it ends up in the trachea, it'll be okay. It's not going to go far enough down that it can go through the vocal cords. This larger balloon is going to sit back in the back of the oral cavity, seal off the upper airway. So when I ventilate, the air is going to come out whole here and enter into the trachea and help cause chest rise. Okay, so recommended sizing is again based by patient weight, and then there's recommended volumes for the cuffs along the side here. So most adult patients are going to fall into this size 4, the red size, where they're 5 to 6 feet tall, and you're going to fill up the cuff with about 50 to 70 cc's. So you need a fairly large syringe to inflate that cuff. So after we place a patient on any of these devices, we want to ensure adequate ventilation. So we're going to be looking for chest movement. So I want to see good chest rise. I want to be listening for equal bilateral lung sounds, so breath sounds in the lungs. I should not hear any noises over that epigastric area, okay? I can also use end-tidal CO2 detection. If I'm in the right location, my patient should be exhaling CO2, and I should be able to see that through either a colorimeter or waveform capnography, which we'll show you in the classroom during labs. And then oximetry, like if I'm ventilating properly, I should notice a change in my patient's vital signs. My pulse oximetry should improve, my heart rate, respiratory rate, blood pressure, all of those things should be improving as well. Okay. Whew, I'm going to keep pushing through. I know this is a long lecture, but I want to get into endotracheal and tracheostomy tubes. So indications for ET tube, this is a relief of the upper airway. Obstructions resulting in laryngospasm, glottitis, or glottic edema. Those are all indications for endotracheal intubation. We do it also to protect the airway. So if I have a patient that's seizing or, is not very responsive, I might prophylactically intubate them just to protect their airway. If I have to suction a lot of secretions out of my patient's lungs, I might choose to intubate them to help facilitate that suctioning if it's bad enough. And then if I need, primary reason we do this is to assist with manual or mechanical ventilation. So if a patient's not breathing adequately on their own, I'm going to have to support that. So I need to have a airway in place, like an ET tube, so I can hook the patient up to our mechanical ventilators and help support their breathing. Okay, so hazards of ET tubes. Because I'm putting this down into my lower airway, I can contaminate the tracheobronchial tree, okay? It's an invasive procedure. So any invasive procedures, as we think back to infection control, can cause contamination to that tracheobronchial tree, can put my patient at risk for infection. Because this airway is down into my lower respiratory tract, I'm going to be kind of bypassing and messing with my cough mechanism. So as oral secretions enter down into my lower pharynx and into my lower respiratory tract, and my patient's cough mechanism isn't going to be triggered as effectively. So that again can mean that my patient could be at greater risk for like micro aspirations of their oral secretions, meaning little bits of their oral secretions is going down into their lungs and could potentially cause pneumonia. This tube is going to be sitting right between my vocal cords. My vocal cords are supposed to open and close throughout the day as I talk, as I swallow, as I cough, as I do a bunch of different basic bodily functions. So if I have a big, plastic tube between those vocal cords, that can cause damage to those vocal cords, and that can result in semi-permanent or permanent damage to my airway. Patients that have experienced long-term intubations do get vocal cord paralysis, which can, affect their breathing and cause obstruction after they're extubated. Again, I'm putting something where it's not supposed to go, so our bodies don't like that, and that can cause swelling and edema, where you can have laryngeal or tracheal edema or swelling from that ET tube being in place. During insertion or while it's in there, it can rub against my mucosal lining, and that can cause damage. This tube, I'm putting a smaller tube inside a bigger tube because my airway essentially is a big tube. The ET tube is going to be smaller than my actual airway, so it's going to be more likely to become occluded than my actual airway because of the size of the fact that it's smaller. So tube occlusions can occur. If that tube becomes occluded, that becomes an emergent situation because I need to get that tube out and remove that occlusion in order for my patient to ventilate well again. Long-term intubations also can result in tracheal damage, like tracheal malacia. This is where the cartilage of the trachea becomes kind of softened, and that can cause it to lose its structure and cause obstruction while the patient's trying to inhale. Okay. And I think your CP Phys chapters go way more in depth about that. And they think there's a very good bronchoscopy video in your CP Phys lecture on airway anatomy that demonstrates this. Okay. Again, because I'm taking a large airway and putting a smaller airway inside of it, I'm going to be increasing my airway resistance. Okay, so things that affect airway resistance, again, I always use the imagery of you're driving in your car. Okay, if I'm on a big highway, I can go really fast, right? If I'm on a city street, I have to slow down because, I'm much more at risk of like bumping into things, and I can't just drive 90 miles an hour down the city street. So same thing with your airways. If I put a smaller airway in, the airflow is going to slow down. That flow of gas is going to slow down. If that flow of gas doesn't slow down, it means I'm going to need a lot more pressure to get that air through those narrow passageways. Okay, so either my pressures are going to need to increase drastically, or my flow is going to need to slow down drastically when I put these ET tubes in. So another common thing with ET tubes, we talked about this in infection control, is that biofilm. So, as these ET tubes, next time you see somebody get extubated at your internships or the summer when you're at clinicals, take a look inside that tube. It's going to be gross. There's going to be like crusty mucus secretions built up on the inside wall of that ET tube, and that's considered biofilm, and that starts happening pretty much right away when a patient's intubated. And that can really restrict the flow of gas through their airways too. So if I notice that I have a patient whose airway resistance is continuously increasing while they're on the mechanical ventilator and they've been intubated for a while, I might look at doing a tube exchange to see if it's because of excessive amounts of secretions in the airway. All right. Along with intubation, we also need to kind of understand which patients are going to be difficult and which patients are going to be easy to intubate. So we use something called a Mallampati score. This is something I fairly certain that you would see on an MBRC exam because this is a great question. Making sure you remember what Mallampati scores tell us and how these classifications work. So Mallampati score is telling us about the difficulty of intubation. So the higher the score, the higher their risk for things like obstructive sleep apnea, the more difficult their intubation will be. So you guys all can do this. Go into the bathroom, take a look in your mouth. say ah, stick your tongue out and say ah. And if you're a class 1, that means you can completely visualize your soft palate in the back of your throat here, okay? Class 2, I can still completely visualize my uvula, but I'm not seeing much of my soft palate anymore. Okay, so class 1 and class 2 mean that I probably am fairly easy to intubate. Class 3, this is when I can only see that base of the uvula, that dangly thing in the back of my throat. If I can only see the base of that, that's considered a class 3. These patients are difficult to intubate. It's going to be very difficult to visualize and see those vocal cords with a patient whose airway looks like this. And class 4 is when I can't see anything besides your big fat tongue. And that means you are extremely difficult to intubate and you're very high risk for obstructive sleep apnea. So class 3 and 4 means very difficult intubations. Okay, so that's an important thing to kind of remember what that means. Okay, so when we're doing our procedure, you want to position the patient. You want to make sure you gathered all your equipment. So you want the correct size tube. You want a laryngoscope blade, a stylet, something to secure the ET tube after you've intubated, and a syringe. Okay. Then you're going to check your equipment. You're going to insert air into the cuff to make sure it holds air, then remove the air again. Okay, it's important that you do this because if your cuff doesn't hold air, then after you intubate, you're not going to be able to seal off the airway and you're going to have to pull that tube out and put a different one in. You're going to insert the stylet into the ET tube and you can bend then the ET tube slightly to help with insertion. That stylet is this kind of semi-rigid wire that helps give structure to that ET tube to help you guide the ET tube where you want it to be during the intubation process. So you're going to take your laryngoscope blade and handle, you're going to insert it in the right side of the patient's mouth, and your laryngoscope and handle should always be held in your left hand. So I'm holding it in my left hand, inserting it into the right side of my patient's mouth, and I'm using that blade and handle to sweep the tongue to the left, to keep the tongue out of the way. I'm going to keep advancing the blade and lifting up until I can expose the cord. Okay. In lab, we're going to talk about Macintosh and Miller blades, looking at the differences, and we're going to look at the differences of what you're supposed to be visualizing or what landmarks you're supposed to be looking for. Because with a Macintosh curve blade, you're going to be inserting it between the epiglottis and the base of the tongue. So you're looking for that vallecular area. With a Miller blade, you want to go under the epiglottis and lift everything out of the way. So you're looking for 2 different views depending on the blades you're using. That will make more sense after you see it in lab. Promise. So once the cords are observed, and you really want to make sure that you got a good view of the cords. If you barely see the cords, you probably want to adjust your view before trying to advance the ET tube. You know, a wing and a prayer isn't going to get this to go where you want it to. You need to be able to fully see those vocal cords if you want that ET tube to pass through them. Otherwise, it's gonna naturally want to slip down below the vocal cords and enter into the esophagus. Okay, so once I visualize the cords, I'm going to advance the ET tube until until I see the cuff or that dark indicator line pass through the cords. Okay, after I have the tube in, I'm going to inflate the cuff, pull the stylet out, and confirm placement. So I do that by listening for bilateral breath sound, looking for exhaled CO2 analysis. I can also look for humidification in the tube. Then I want to secure the tube in place and obtain a chest x-ray. Okay, when I get the chest x-ray back, we have a radiopaque line on the ET tube. So that means that there's a line on the side of the ET tube that's radiopaque that makes it show up on x-rays as a white line. So if you look right here, I'm going to draw it on with my little drawing tool. This right here is my radiopaque line right there. And then I've blown it up so you can really see it. And it's right there. Okay. So those are where the radiopaque lines are. So I'm looking at that, and then I'm looking for my carina. So this can be kind of tricky to see. Your carina is where the bronchi branch. So on this patient here, my bronchi look like they're branching right about here. Okay. So I want to make sure there's about 3 to 5 centimeters between this bronchi here and the tip of my ET tube. Most radiologic software gives you a little measuring tape that you can measure, but also you can count ribs. Usually the thoracic third rib is where the ET tube should end up being. The top rib got cut off on this one. That would have been 1, 2, 3. That's your T3, so that's in good position. So T3 or T4 is where you're going to be considered in good position. Okay, oops. Exit drawing. Okay. All right, some complications associated with intubation. If your patient's conscious or semi-conscious, they're not going to tolerate this well. You wouldn't either. It is if somebody sticks a laryngoscope blade in the back of your throat when you're awake, you are going to vomit. So you need to make sure the patient's completely sedated. AT tubes can sometimes be difficult to stabilize, meaning secure. You can, with intubation, a lot of times patients have a lot of excessive amounts of oral secretions, which isn't good. They get really, really drooly. So you'll see a lot of ICU patients getting treated with like scopolamine patches. They're like a little patch that we put, medicated patch we put behind their ears to help with kind of drying up some of those oral secretions. Patients who have really strong gag reflexes can gag or cough on the tube a lot. Patients can become irritated and then bite down on their ET tubes, which occludes their airflow. Because this tube goes through your vocal cords, you're not going to be able to talk. Okay, so it's going to be very, very difficult for you to communicate. And with any type of invasive procedure and having to wear fixation devices, and when we're in lab with this, we'll talk about different fixation devices, that can cause a lot of skin breakdown as well. Okay, so nasotracheal tubes are kind of an alternative to oral tracheal tubes. We rarely use nasotracheal tubes. Typically, we're doing this for blind nasal intubations for non-emergent difficult airways. So this means that the patient's alert and breathing. But we don't want to sedate them and orally intubate them because they might be that patient who has a Mallampati score of 4. And we look in their airway and go, ooh, that doesn't look good. I don't want to mess with that. I'm not going to take away your drive to breathe with medications that are required to orally intubate you. I'm going to do a blind intubation and intubate you nasally. So typically what you're going to do with this is you're going to insert the endotracheal tube through the patient's nose, just like you would insert a nasal trumpet or a suction catheter. You're going to keep inserting it, and telling the patient to take deep breaths, cough, that helps them open up that airway. Putting the patient in the sniffing position while they're doing this tries to direct it into the trachea. Once the patient's not able to talk around the tube, or their vocalization becomes difficult, you probably are through the vocal cords. Then you can inflate the cuff and stabilize it, and then sedate the patient for comfort. Okay, but the patient's awake during the procedure so that they're controlling their breathing, because again, if they get sedated for intubation, we knock out their drive to breathe, we paralyze them, and then we're solely responsible for ventilation, which can be very difficult in somebody who has a known difficult airway, like somebody with a high Mallampati score or high BMI, or any other types of facial anomalies that may maybe make us think that it would be difficult to intubate. So advantage of these is these are usually easier to stabilize than oral tubes, and they're usually typically better tolerated. It's going to be a lot more secure in the nose and in the mouth. Again, complications can be skin breakdown. You might end up with ear infections just because this endotracheal tube is close to your sinus cavities, so that can cause, which is connected to your ears, so that can cause some ear infections. So all of those things are some difficulties with nasotracheal tubes. We also sometimes do nasotracheal intubations when the patient has a lot of facial trauma too. Like if we don't trach them, we might consider doing a nasal tube, but typically we're going to choose tracheostomies in those situations, emergent tracheostomies. Okay, some other little differences with ET tubes. We have something called a high-low evac tube. These are used to help prevent ventilator-associated pneumonia by suctioning the secretions that kind of rest above the cuff here. So if you think about your airway where your ET tube goes, these are your vocal cords here. This is a cuff that's going to seal off your lower airway. This space in here, a lot of oral secretions can pool on top of this cuff. And I can't really suction those by orally suctioning them. I can't suction them by suctioning down the ET tube. So they just kind of sit and rest there, which can cause more complications. Again, the more that sits there, the more likely you're gonna have those micro aspirations and end up with ventilator-associated pneumonia. So some genius designed these high-low evac tubes. This suction lumen here can be hooked up to a suction canister, and typically it's put on either continuous or intermittent suction, like low pressure continuous suction or intermittent suction, and it's just going to remove any subglottic secretions that kind of pool in this area. Okay. ET tube exchangers. These are devices that we use in the critical care areas anytime we feel like our ET tube has become compromised and we need to remove it and put another one in. What's nice about these is they act kind of like a stylet. They go down the inside of the endotracheal tube, and we're going to play with these in lab. These go down inside the endotracheal tube, come out the bottom. I can then pull the tube, the ET tube, off and leave this exchanger down in the airway. And this just becomes like a track that I can put another tube over top of and insert it right in the airway without having to go through the whole rigmarole of intubation. So it's a kind of a placeholder for where your ET tube has to be. So these blue guys here, these are called bougies. So these are commonly found. The benefits of bougies are, simple to use, easy to kind of pop in, pop out. They also have Cook tube exchangers that have these little adapters on the end, and those typically have a opening at the bottom of this that allow you to ventilate through this very, very, very small, tiny tube, just in case you need to, while you're doing this procedure, you need to provide ventilation to the patient. So again, we'll play with these in lab. But that's kind of what ET tube exchangers are, what they're for. So if you blow a cuff on your ET tube and you're no longer able to keep that seal, you can exchange the tube with one of these. If you decide that you need a larger tube than what you originally placed in there, you can use one of these to get a larger tube in. If you decide that you think that there's a bunch of crusty biofilm building up on your endotracheal tube, and that you want to exchange it out for a nice, clean, clear one, I would recommend getting a tube exchanger to do it. All right. So real briefly, there's a lot to talk about tracheostomy tubes, but real briefly, tracheostomy tubes, these are indicated to bypass upper airway obstructions. So these are for patients who I cannot get an endotracheal tube through my upper airway because of some sort of obstruction. I'm going to need to trach the patient. We also do this to prevent problems posed by oral and nasal ET tubes. So if my patient's being intubated for a long period of time, I would probably want to remove the oral tube and put in a more permanent or semi-permanent tracheostomy tube. Tracheostomy tubes allow patients to swallow and eat, so it's a lot better kind of quality of life for a patient when they're trached versus intubated. So you see these a lot in long-term care facilities. Endotracheal tubes usually aren't supposed to be used for longer than like 21 days. So after about 21 days of being intubated, usually the recommendation is to do a surgical trach placement. All right, so my complications went bye-bye. So complications with trachs, again, it's invasive. So some of the same complications occur with trachs as with ET tubes, in the sense that it can increase your risk for infection. But the nice thing about tracheostomy tubes over ET tubes as well is that it helps facilitate weaning from the ventilator. If you think about the amount of dead space that's in your upper airway, so if I trach you, I'm putting a tracheostomy tube kind of halfway down your airway. That cuts your volume, the volume that you need to get into your body significantly. It cuts it down significantly. So your work of breathing actually decreases when you get a trach versus when you're intubated. Tracheostomy tubes, though, like I said, are still invasive. Your risk for infection does increase. Your risk for tracheal damage also increases. So tracheal stenosia, tracheal malacia increases with these versus ET tubes as well. Okay, so you have, again, we're going to go way more in depth into tracheostomies in a future lecture, but you have fenestrated trach tubes and non-fenestrated trach tubes. So fenestrated trach tubes have a hole in the top. This is called a fenestration. This is a hole in the top. It's used to help wean patients off their trach tubes because that hole sends air up through the vocal cords, allows the patient to talk. You can't use this with an inner cannula, though. If ventilation is necessary, you would have to put an inner cannula back in and reinflate the cuff in order to put the patient on the ventilator. Okay, so that's just real briefly tracheostomies. We are going to talk way more about that in a future lecture, but that kind of gives you a pretty broad strokes overview about some of these airways, and I apologize for this being a super, super, super long lecture.